I get whispers in stereo. 2022, we're at the Deuk Spine Institute Surgery Center Vieira. Our patient today, our first surgery of the day, has 2 herniated discs in his neck, C3-4, C5-6. They're small herniations. Most people would call them a bulge/herniation, but the origin is the same. There's a tear in the back wall of the disc. This wall is called the annulus fibrosus, and through that tear, the jelly in the center of the disc has pushed out through the tear and is bulging out. And that's the herniation part. So there's 2 steps: annular tear, herniation, and that's what causes the neck pain, irritates the nerves, causing arm pain, weakness, and numbness. We call it radiculitis or radiculopathy, depending on how much damage there is. We're going to be fixing C3-4 and C5-6. Let's go ahead and get started. I'm going to first place a needle at C3-4. We're going to be making 2 incisions. I can possibly do both with 1 incision, but I think it's going to be a little bit safer for the patient to do 2 separate incisions. So they're pretty far apart, and it's just safer that way. Shot? All right. So you see we're going to have to go up pretty high. Shot. All right, so we're pretty close now. Shot. That's good. Let's give us an AP. We're going to be using X-ray to find the proper disc that we're fixing. That's 3-4. And that's right where the needle is, sitting over the 3-4. I'm a little bit too close to my side. Could you hold his head, please? Sure. And, yep, let's go back to a lateral. I'm using my left hand, my index and middle fingers to press down on the spine, and I'm actually feeling the patient's spine and their discs. AP. Now I'm in the front of the disc at C3-4 with the needle. I want to make sure I'm in the midline. Shot. That looks like I could be a little bit more over to the midline. So lateral. Quickly. Good. Shot. Let's get that shot, and then AP. Quick. That's good. Lateral. Perfect. I'm happy with that. So we're right in the front of the C3-4 disc. I'm entering the disc now with this needle. Shot. All right. And we're going to basically plant this needle here and leave it until we come back. Shot. All right, that's perfect. I want to get it deep enough that it doesn't move or come out while I'm working further down the spine. Very happy with that right there. Very good. Next, I'm going to go down to the C5-6. I'm going to give my fingers a break for just a minute. And then we're going to go in and get our needle into the next disc, which is C5-6. Go ahead and, Jordan, will you show our audience how we're counting the levels? Show them C2. It's a tall bone up there. Yep. Further up. Goes all the way up right there. That's the top of it. So Jordan is showing you C2. Show them C1 in front of the top of C2. Go, yep, right there. That's C1. You guys see the arrow, Henry?
Yes, we see it.
We call that the anterior arch of C1. Then you got C2, which looks like 2 vertebrae fused together. And then you go down, C3, next C4, and you can see the needle is at the C3-4 disc, which is the top disc we're going to be doing. And then C5 and C6. And we're going to be doing the C5-6 disc next. Oh.
I have a question. Can we then start with that one and then proceed with the next needle? I think it's going to be kind of tough trying to, you know what I'm saying?
Sure. Yeah.
Or next time I would use the DPR needles one. They're short.
Uh-huh.
You know what I'm saying?
No problem.
Yeah.
All right, Luis wants us to start at C3-4, so that's what we're going to do.
Yeah.
All right, let's get started. The next step after placement of the needle is a discogram. And the discogram is done with 2 types of dye. One is radio opaque, the other one is a a dye that stains herniated discs blue. Shot? I could feel the dye going in. Look at the tear there. Show them you can see the herniation, by the way. Show them the small tear right there. Yep, that's it. And the herniation right there, sticking out back. So that is the C3-C4 herniation. Let's get an AP. Just so you guys understand, lateral means a side view on the x-ray machine, side to side. AP is front back. We use both views, AP and lateral, to navigate. Looks perfect. You can see the endotracheal tube. You can also see the esophageal temperature probe. All right.
Both expertly placed.
Yes, both expertly placed by our expert anesthesiologist, Dr. Berndes. Now, Henry, let's go ahead and show our audience. I'm going to do some numbing of the skin, and let's show our audience while we're doing this with one of our videos. Why do herniated discs in the neck actually cause neck pain and arm symptoms? It's really inflammation that does it, and we're going to show you a quick video that explains how that happens.
Traumatic injury on the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissue develops within the annular tear, causing neck pain. The inflamed annular tear generates pain signals. Additional injuries can cause worsening symptoms. Inflammation from the annular tear can spread to the nearby nerve roots, causing arm pain. Pain signals travel up the nerves to the brain, causing localized neck pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of neck pain. If you have a herniated or bulging disc and neck pain, submit your MRI for a free review at www.mri.deukspine.com.
All right, welcome back. You can see from the video that that's a beautiful placement right there on the x-ray. Go ahead and look at the x-ray. See the tip of the dilator is right in the middle of the spine. That's exactly where we want to enter. The front of the disc is in the middle. And of course you have some leeway, left and right, about a centimeter each direction. All right, so I'm going to advance this dilator forward, and as I was saying, you could watch the video and you can see that the herniation gets its origination from the tear in the back of the disc. It's called an annular tear. Shot. And you cannot have a herniated disc without an annular tear. It's impossible. Shot. Mallet. Yep.
Can I record
Yep.
it? Yeah.
We're going to take the guide wire out because we're starting to go into the disc. We're going to pass through the annulus fibrosus in the front of the disc, and we're spreading the fibers, not tearing them. And we're going to pass through this inert jelly in the middle of the disc and make our way to the back of the disc where the herniation is. Now, the only part of a disc that causes symptoms is the back of the disc. The front never causes symptoms, and we never treat the herniations that occur in the front of the disc. You can see from that picture right there, show them the tip of the dilator at C3-C4 at the back of the disc sitting in the tear, and you can see the herniation, outline the herniation. The reason you're able to see that is that black dye, which is omnipaque. Now, we've made our skin incision already with a number 11 scalpel. It's 4 millimeters, which is the exact width of this tube where we're doing the entire surgery. Okay, so we're going to bring the tube down the dilator. Meanwhile, we're going to use our X-ray machine to again navigate the tube to where I want it to be. Shot. You can see the tip of that tube right there in front of the endotracheal tube, and it's working its way down. And I'm going to make contact right now with the spine. I could feel it. Shot. You can see show them the tip of the tube in the front of the spine. Meanwhile, the dilator has moved backwards a little bit. Okay, that's because, believe it or not, there's so much inflammation in this disc, it's literally pushing the dilator back out. It doesn't want it there. It's pushing it out like a bullet coming out of a gun, but not quite as fast. Shot. So we're going to have to advance this tube down through the disc, and you can see the dilator once again is coming backwards because of the pressure inside the disc. And we do this slowly and carefully. You got to watch the tip of the dilator, make sure it doesn't advance too far or go back too far. All right. So Luis, when was the last time you were on the Velocicoaster? Take that off.
Last time? Oh.
Shot.
I don't know,
Shot.
maybe 2 months.
All right, put it back.
What any changes?
No,
Oh.
just wondering.
Oh, okay.
For those of you who don't know what the Velocicoaster is, it's a ride at Universal. It's, in my opinion, the best,
Oh, it is amazing.
right? The best roller coaster
It is.
I've ever been on. And you can go to the front if you're really a fan of roller coasters and ride it from the front. Have you been on that, Henry?
I have not, no.
You seem like you'd be a roller coaster guy.
I am a huge roller coaster guy. I love Universal. I just never been on that per se.
Yeah,
Oh.
you need to go and get on the Velocicoaster. It's about a 45-minute wait, usually.
Oh, that's
But
actually
it is 1,000% worth it.
even then. I'm like, that's not a bad roller coaster wait time compared to
No,
the
no.
others.
Endo, please.
All right.
On the roof.
So go ahead and show our audience, Henry, the scope. Can you guys see this?
Yes, yes. Now we do.
We have a camera, high definition, with a scope, a laser fiber, irrigation, a light source, which actually gives us illumination at the end. Let's go ahead and turn the light source on, if it's not already on. And we're going to head down this tube, and you can see the laser there coming out the end. Now the laser energy is transmitted from a machine, which is at the feet of the bed, and the laser energy is transmitted to the end of this glass fiber. You guys can see it, the 12 o'clock position. Okay? All right, laser's on at 20. Now these little blue things are pieces of herniation. Already they're starting to come out the tube. We're using this tube then to really gain access to the back of the disc where the herniation is, but also to allow the pieces of herniation to be removed right through the tube. So not only is the tube giving us access to where the annular tear and herniation are at the back of the disc, but it's also allowing us to remove the pieces of herniation, little pieces at a time.
Thank you very much.
So it's a path of egress. Now let's go ahead and let our audience see, what is this Deuk laser disc repair all about? What are we doing here? I think we're a little overexposed on the camera. We need to bring the light down a click or two. It's a little too bright.
Playing video in 3, 2, 1.
Disc
we go, that's
herniations are
right
a
there.
common cause of neck pain. The inflamed annular tear causes neck pain. Inflammation of the nerve roots causes arm pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. It can take up to 12 months. If you have a herniated or bulging disc and neck pain, submit your MRI for a free review at www.mri.deukspine.com.
All right, welcome back. You can actually see we are at the back of this C3-4 disc, and what we're looking at here is fibers of the posterior longitudinal ligament, and that's behind the annulus. So you can see the annular tear. I'm working on it right now. I'm debriding it, but that is the annular tear right there. And I don't see any puncture through the PLL, posterior longitudinal ligament, but yeah, we're just cleaning out the little bits of herniation that are here that we can see so far. And I was just talking about Halloween Horror Nights with my crew here at Universal Studios in Orlando, and we were talking about the RIP tour, which is basically you pay a little extra money and you get to go to all the houses in one night. And we've been doing it for years now, but we've never gone to all the houses because I can't stay awake for all 10 houses, you know? For me, it's impossible. But we usually get to about 5 haunted houses. All right, so this is all herniation that we're taking away, okay? And that 12 o'clock position where the laser fiber is doing its work, debriding, that's actually to the patient's left side. And that's the left foramen over there, neuroforamen. It's incredible what you can see endoscopically. And I was having a conversation with somebody the other day about how I can actually tell how old these herniations are now because of all the experience I've had doing this. Like this piece right here, I could age this piece of herniation right here. Now it's probably around a year old, that particular piece. But you can see there's a mixture of different age herniations. We have determined that the average herniated disc has around 20 pieces of herniation, which means they had 20 herniations after the tear was formed. And each one of those herniations happens at a different time. Now, some of them may all occur, within a few days of each other or even on the same day. Depends on the activity of the patient and when it happened. But what we found is that the older the herniations, the more calcified they are, the more collagenized they are. Collagenization means infiltration with collagen. This is another piece of herniation I'm working on right now. This one is probably around the 1 to 2 year mark. And the tear itself is older. You can see the tear right here. Looks to me like it's several years old. Now this is C3-4, just for reference. Our patient has 2 herniations. One is C3-4, the other one is C5-6. We haven't done C5-6 yet. That's our next stop after this is done. Now this patient is traveling to us. There's a herniation right there. You see how it just came out of the foramen? Beautiful. That is a fresher herniation. That thing looks like it's probably within the last 6 months. Let me try to grab it out. It's even got some pink material on it. Did you see the granulation tissue? That's a sign of inflammation going on related to that piece of herniation. Let's see if I got it. Did I get it, Luis? Did you see anything on there?
Yeah,
good. All right. Any questions from our audience? If you're watching the surgery, feel free to ask me questions during the surgery. I can answer them for you or try to answer them for you. We also have a question answer period at the end of the surgery where I will come in and do direct face-to-face answering of your questions. Henry and I. Any questions from our audience at this time?
We have a couple comments, and we do have a question, but they haven't asked it yet. This comes from Federico Alvarez Gomez O'Meal on YouTube.
All right, very good.
And they said, first of all, God bless you all there in the op room. I have a question.
Thank you.
And no, nothing else was typed after.
All right, well, we'll wait for Federico to give us the question in a few minutes.
Of course.
In the meantime, we'll keep working. Now, you saw the video earlier on how does a herniated disc actually cause neck pain and even arm pain, and it's through inflammation. And that's something that most doctors really actually don't even know. And that's why we're trying to get the word out. There's a piece of fresh herniation, the blue stuff. So it's really important because doctors are always looking for big pieces of herniation to blame the patient's symptoms on. But what we find is that most of the time there is no big herniation. It's small, but as they say, deadly. Those small herniations can cause horrible pain because of inflammation. You don't need a big herniation to cause a lot of pain. So there's this, unfortunately, a myth in the spine world that only big herniations cause big pain or big symptoms. And that's absolutely the furthest thing from the truth, which is why, unfortunately, a lot of people with horrible neck pain and back pain are not treated by their doctors. They're marginalized and told there's nothing wrong and I can't see anything and you're going to have to live with it, because the doctor doesn't understand that a small herniation can cause big pain through inflammation. And if I go in and fix those small herniations with this Deuk laser disc repair surgery, that we can actually get rid of the pain permanently for the patient when it's coming from the herniated disc. All right, so far so good. These are all herniations right here. They're all on the left side, which is where the patient's most of his symptoms are. I'm sorry, where did we say our patient is visiting us from? Orlando? Are you sure? No, we have some local patients. This one is from Orlando, just an hour away. Orlando, Florida. Typically our patients come from other states, other countries, but this is a local patient.
We have a couple questions.
The next one's from Tampa. All right. Yes, we'll take the questions.
Yes.
Those are pieces of herniation, by the way. The little blue things. Yeah.
This first question comes from Saul Sotelo on YouTube.
Hello, Saul. Welcome to our live stream from Deuk Spine.
And they asked, I have a hernia on the T4. How long will you guys take for all the process from when I send my MRI CT?
Hi, Saul. Welcome to our broadcast. How long will it take for the process from when you send your MRI or CT? The answer is we don't know. If you do the upload properly and you fill out all the questions and you get us those images right away, it usually takes about a week to get your MRI review done for free, and then another week or two to get you in for surgery. So I would say it just depends on how motivated you are, Saul. If you're really motivated and you want it done quickly, we can get it done quickly. Usually we can have you here within a week to have your surgery. So we have a new MRI review person. Her name is Sam. She's very smart and wonderful and enjoys helping people. So she's taken over for the last one who unfortunately just quit, walked off the job, and left a lot of people hanging. But my best answer to you is we can get it taken care of usually within a week. Now this is a much older piece of herniation way out here. It's very collagenized. scarred. That only comes from time and a long time with inflammation. Great question though, Saul. Thank you for asking.
We have a few more.
Sure.
This next question comes from Varush on YouTube.
Hello, Baruch.
And he asked, "Hi there, God bless. My question is, can neck disc bulge cause vertigo?"
Did you guys see that herniation right there that just came out of the foramen on the left? That was a piece of herniated disc in the foramen. All right, so the question, there's another piece that just came out of the foramen. Beautiful, huh? So the question was, can a herniated disc in the neck cause vertigo?
Correct.
The answer is, I would say no. That's my answer is no. It would be extremely unusual for a herniated disc in the neck to cause vertigo. I would never tell a patient to expect surgery to fix their vertigo if I'm operating on a herniated disc. That doesn't mean it couldn't happen. I just not seen that happen before. And I wouldn't recommend getting surgery on your spine for a herniated disc to treat vertigo. And just so you all know, what is vertigo? Vertigo is the sensation that the room is spinning around you. Patients with vertigo actually see the room spinning. Like if you're looking at a chair and you have vertigo, the chair will move to the side or up and down, depending on the type of vertigo you have. It's really based on what's called nystagmus. And nystagmus is abnormal movement of the eyes. And if the abnormal movement is up and down, then you're going to have vertical vertigo. And if the movement is side to side, you'll have horizontal. There's more herniations coming out of that C3-4 foramen on the left. Pretty cool, huh? Honestly, I'm a little bit surprised because on the MRI scan, I didn't see this many herniations on the left side at C3-4. There's another piece right there. Now that's an older herniation. Look at how smooth it is. That's several years old, and look how calcified it is. That's not a recent one. I'm trying to get it to come up the pipe and leave. It's not a welcome person. It's not welcome in the spine. We want to get out of here. I'm going to have to get the grabbers. Great questions so far.
We have a few more.
We'll take all the questions you can give us.
Beautiful. This next question comes from Federico on YouTube.
Hello, Federico.
And he asks, "Thanks, doctor. I have thoracic T7-8 medial center touching the cord. It's not classified, and I wondered because I didn't see in your videos how the approach of the laser in this kind of medical center discs."
Yeah. So great question, Federico. If you go back to our YouTube channel, is he watching from YouTube or Facebook?
YouTube.
All right. So Federico, go to our YouTube channel and you can find on the playlist. You have to go to playlist, and you can see the Deuk laser disc repair thoracic, and we have several testimonials there. And I know we have some surgeries as well that were done, but we thank you. We definitely do thoracic herniations with the laser, and the approach is through the back. It's called, this is a bone spur, by the way, right there. See what I'm blasting with the laser? That's a bone spur. Okay, so we can treat thoracic disc herniations with the Deuk laser disc repair. There's another herniation right there, 2 pieces. I'm breaking them up and removing them. There's a lot more herniation at C3-4 than I originally expected. When I first saw the MRI, I didn't see this much herniation. And they're very dense pieces. You see how they don't want to float out so easy. So yes, we can treat thoracic disc herniations, but before I tell you we can fix yours, I would really need to see yours. So use the link that Henry's going to post for the free MRI review, and I'll be happy to look at your thoracic MRI and tell you if it's something we can fix with the Deuk laser disc repair. These are all pieces of herniation. Every piece that I float out is another piece of herniation. You can see how many there are here. The MRI never shows you how many pieces of herniation there are, but the endoscopic surgery does. You can count them. And that's something we've been able to do that no other surgeon in the world has ever done, is to count how many herniated pieces there really are in a herniation. Any more questions?
Yes. We first we have a comment from Saul, and then we have a question from Sue Griffin on Facebook.
All right. Hi, Sue.
And Saul's comment was, "Yes, I am. I have lost mobility in my knees, and I have been fighting this since March. I'm still fighting to get my surgery done. Thank you."
All right. Good. Good luck to you, Saul. We hope you get your surgery done.
And then the question comes from Sue Griffin on Facebook, and she asked, someone on the support group asked when the disc seals after DLDR, does it refill over time? What difference does the reduced shape / height make?
All right. Very good. Thanks, Sue. Yes. After you have the question is, after this surgery, the Deuk laser disc repair, does the disc heal and seal? The answer is yes, but it takes about 9 months to a year to fully seal, and it seals right where we're working, right here. All this empty space will seal with collagen. What is collagen? Collagen is what the disc is made out of. Specifically, the annulus fibrosus is made out of collagen. So the disc is going to seal with collagen, which is basically the annulus is repairing itself. And that's why we call this an annular debridement, because we're actually cleaning up the back wall of the annulus so that it will seal itself. Now, it cannot seal without the Deuk laser disc repair. Why? Because it has this jelly right here. You see the blue stuff? This is keeping it from sealing. It's like you trying to close your front door and somebody steps in there and puts their body right there, the blue stuff, blocking it from sealing. See, this white stuff is the annulus, and the blue stuff is the herniation of the nucleus. And you cannot seal the annulus by itself unless the nuclear material is removed. And the Deuk laser disc repair is the first surgery in the world to do it, and it's the only surgery in the world that does it. Nobody else has ever published a procedure about annular debridement except us. So everyone else takes the whole disc out and fuses it, or takes the whole disc out and does an artificial disc. Great question, Sue. Thank you for asking. Hopefully that answers it for you. You can see all the scar tissue here as the disc is trying to heal for years and years, but it's unable to. All right, that's looking pretty good. I think we're just about done here. Little trapeze artist of a scope. Any more questions for us? We're about to finish C3-4.
No current questions, but we do have a comment from Frederico on YouTube. And he said, "Thanks for the answer. I'm a fan, and I've watched all the thoracic videos. I'll fill the free MRI form. I'm from Argentina and waiting. God bless you."
Okay, very good, Frederico. Thank you. If you don't hear from us within a week of filling that form out, then let us know. We are not going to be doing surgery this week on Thursday. We have a hurricane coming here from the Caribbean, a gift from Cuba and Africa originally, of course. So we are not doing surgery this week Thursday because of the hurricane. So we're doing all of our surgeries today. But if you have submitted for an MRI review and you got us your MRI, you should hear back from my team, specifically Sam, and she should be scheduling you for an MRI review. I know our next MRI review date is Friday, this Friday. So hopefully you're going to be on Friday. If you want to give Sam a call, why don't you put the phone number down there for Sam?
Copy.
It's 321
Mm-hmm.
775 1299. That's USA. 321 775 1299.
Copy that.
How's our irrigation? These pieces are not coming out. I feel like the pressure's a little low. Yep. These are not big pieces. They should float out. There we go. Now they're floating out. Just about done here. I need 5 minutes maximum, maybe even less. It's just the never-ending herniation. You know, when you look at the MRI, 3-4 didn't look that bad, but now that I'm in here, it looks 10 times worse. And I'm glad we're doing it because I think he would have had a lot of problems from this particular herniation if he didn't fix it. The number 5-6, I think, on the MRI looks worse. But the 3-4, internally, it just goes to show you how you can't trust the MRI. The MRI is not reliable. A lot of people rely on MRIs too much, and it's a problem because they make decisions for patients just based on the MRI when they shouldn't be. I try to teach people that. Everyone wants to show me their MRI report and say, what do I need to do? And I say, you can't tell based on an MRI report. You need to examine the patient. You need to have an exam. Without the exam, you cannot tell what's wrong. So that's why we do the free telemedicine where we do a Zoom conference and we can actually look at the patient and see. Just about done. It's surprising how much damage there is on the left side at C3-4. It's very surprised. Didn't see this on the MRI. But his symptoms were on the left side, so it makes sense. The patient always tells you where the problem is. You can't rely on the MRI. The MRI is wrong most of the time. We're done.
Scuba lights on, please. Thank you.
It's one of the biggest problems is all the doctors that rely on the MRI. They're doing the patient a disservice. All right, we put some antiseptic in. We are irrigating it out. Antiseptic is a topical antiseptic. All right. At this point, we're going to remove this tube. We're going to leave the dilator in, but I need to get the x-ray machine in here. You can see that we've made a small incision. It's 4 millimeters. We're going to make a second incision in just a moment at C5-6 and fix the second disc. I probably got out about 90% of the herniation there. There's always going to be around 10% that's left. what I found is you need to get rid of at least 50% to get the symptoms to go away. Is that where we are? That's it?
Yes, sir.
All right. I'm going to remove the tube. Shot. Uh-huh. Shot?
I mean, you wanna go down?
No, you're right.
Oh, okay, yeah,
You're right.
yeah.
It's just habit.
Okay, yeah.
Yeah, we're gonna not be able to go down. We're gonna put another needle. So we'll just hold pressure for a few minutes in case there's any vein bleeding. The beauty of this technique, folks, is that it's so minimally invasive. Watch the laser tip, just the tip right there. It's so minimally invasive that the only damage we're doing is to the skin. We have a tiny little cut. It's 4 millimeters. You can see it. And that little cut is actually the only place we're really causing any damage for the patient. What's the issue?
No, it's just
Oh, for 5-6?
the ceiling. Fitting off, yeah.
All right. Any questions from our audience?
No current questions.
All right. Let's go ahead and get the head up and down, derotated. Do whatever you got to get them straight up and down. Good. And I'm not ready yet. I want to hold pressure. We have a little bit of venous bleeding. It's probably, if I had to guess, an external jugular or a little subcutaneous branch. External jugular is not the same as the internal jugular. External jugular vein is a small vein. It can be sacrificed, eliminated without any problems. Internal jugular is very different. It can also sometimes be sacrificed, but you never want to sacrifice the internal jugular if you can avoid it. All right. Let's go ahead and show our audience one more time the video on why do herniated discs cause pain, so they understand the annular tear and the relationship of the annular tear to the herniated nucleus pulposus while we're waiting here.
Traumatic injury on the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissue develops within the annular tear, causing neck pain. The inflamed annular tear generates pain signals. Additional injuries can cause worsening symptoms. Inflammation from the annular tear can spread to the nearby nerve roots, causing arm pain. Pain signals travel up the nerves to the brain, causing localized neck pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of neck pain. If you have a herniated or bulging disc and neck pain, submit your MRI for a free review at www.mri.deukspine.com.
All right, we're still here and getting ready to do the next disc, C5-6. Were you able to get the MRI images by any chance, Henry?
Unfortunately, no. I'm sorry.
All right, no problem. Well, folks, if I could describe the MRI, if you're looking at the MRI, you're going to be looking at C3-4 and saying, gosh, I don't really see anything on the mid-sagittal view. But then when you scroll the MRI images off to the side, that's where you'll see the small disc bulge herniation. And again, the MRI shows 10% of the damage that we're actually seeing once we went inside the disc. And the patient definitely had symptoms coming from C3-4. His pain was localized over the C3-4 and the C5-6 both. He had radicular symptoms indicating irritated nerve roots as well. And that's why we went ahead and decided to fix both discs, even though the 5-6 was, you know, on the MRI, it was a lot worse looking. So we're just about done. When you have a little bit of venous bleeding, you want to hold pressure for at least 4 minutes. And the problem is, you know, these times that they give you of holding pressure for veins, those are based on normal patients with normal platelet and coagulation profiles. But when you have patients these days, so many of them are on herbal medications that thin their blood and impair the platelet plug from forming, you're going to have to hold for longer periods of time. So I always think of 4 minutes as being the very minimum amount of time you hold if you have a little bit of venous bleeding. Let's go ahead and show one of our patients who had this surgery done recently and did a testimonial for us. Can you do that, Henry?
Yes.
I think the laser is the best thing out there to have with this type of surgery. It's all legit. That's all I can say about it.
Dr. Deuk here at the Deuk Spine Institute. I'm with one of my patients who's traveled to us from Mississippi, and he came here for the Deuk laser disc repair to be done for a herniated disc on his neck, and he's now here today, just one day after surgery. How are you feeling today?
Feeling great. Feel like the weight of the world has been lifted off my shoulders. Feels a lot less pain in my shoulder, no more tingling. Feels like my body's trying to recover back to normal. I think the surgery went very well, no problem whatsoever.
And you're just one day after surgery. Can you tell whether the neck pain is gone yet?
The neck pain is gone, and the pain throughout my shoulder, the tingling, everything's gone. A little soreness in my throat, my voice is a little harsh, but other than that, I feel great.
Awesome. Can you show us your incision? Oh wow, look at that. So you have a 4mm incision. You can see that right here on the surgical footage of the endoscope. We actually, when you watch the video, you can see all the herniated discs back there. We were pulling them out one at a time. You had about 20 pieces. And then you can see the nerve root right there in the foramen. And there's no herniated discs anymore on the nerve root. We got them all out of there. I had to open up the posterior longitudinal ligament and get all those fragments of disc herniation out of the epidural space that were pushing on your nerve. And I got a good look at everything and it looked fantastic. So I think you're gonna do great. Did you consider having like a fusion surgery? Did anyone offer you fusion before?
Yes, I was offered fusion. I was told that was the only surgery that could be done. I started Googling. I come across the laser surgery and I decided to give it a try. And I don't regret it. I think it was the best decision I ever made for my age, and I think the outcome would be a lot more better in the future. And it was a great experience. It really was.
And you work with metal as your job, so you didn't want metal in your neck, on your spine.
No, I think the cold weather would have an effect on it. I think it would have caused an adjacent effect, is what they call it. When you do the fusion, it make the disc below it or above it wear out. And I'm 34 years old, and if I live another 30 years, I just feel like it would cause significant problems. I think the laser is the best thing out there to have with this type of surgery. It's all legit. That's all I can say about it.
All right, well, you guys were watching our video. We have already placed the next spinal needle at
I think
5-6. Yeah, go ahead and, well, we'll do an AP in a second, but I was happy with the original AP positioning. So we're going to go ahead and do our discogram. Shot. Okay. We need a little shoulder pull, Luis, on your side, just a little, and shot. Hold on. Oh, interesting. A lot of scar tissue in this disc. A lot. Shot. So this looks like it's going to be an older injury, and because of that, there's a lot more scar tissue inside the disc. Shot. All right, there we go. So let's show them, Jordan, count down from C2 again, so we can show them what level we're at. 2, 3, 4, 5, 6. This is the C5-C6. Show them the herniation. Yep, there it is, outlined by the dye. And at this point, we're putting our guide wire in, and I'm going to bring the shot. I'm going to make the incision in just a moment. We need to infiltrate first. We're good, we're good, we're good. That's perfect. Yep. So we're going to numb up the skin. It's the second incision we're making. I told the patient we're going to be making 2 incisions. He was fine with that. Each one is 4 millimeters, so it's tiny. And, you know, the alternative would have been to do a fusion surgery, which he didn't want. And I don't blame him. Nobody wants fusion. But let's go ahead in a minute. We'll show our audience the difference, shot, between Deuk laser disc repair and a spinal fusion. Shot. All right, very good. I'm taking the needle out and I'm leaving the guide wire. What's the problem, guys?
No problem. I'm just
Good.
saying, like, me pulling only this one.
It's fine.
It's fine.
That's all we need. Did you pipe clean this by any chance? Yeah.
Do you think
I don't know. Put a little pressure here.
yes, sir?
Gentle. Let me see. I think we're okay. Shot. Just don't let the guide wire go further in. Perfect. Okay. Let me see. Perfect. Yeah. Shot. Again, we're going to advance the dilator down the guide wire. And he's got, I can tell you already, he's definitely got an external jugular that runs right along shot the sternocleidomastoid. Shot. Perfect. Let's get an AP view. Remember, the AP is the front back. Shot. Perfect. We're right in the midline. Lateral. So at this point, I have my dilator tip right in the middle of the spine where we want it, just in the front of the disc at C5-6. You can see the herniation in the back of the disc. That's what we're going to be going after and removing. Remember, people, herniations are not one piece of disc. It's actually a collection, like a bag full of marbles. And, you know, how many pieces of herniation are in that bag really just depends on how many times the patient herniated their disc. But never is it one piece. I think maybe in a 500 surgeries, you'll find one that has a single herniation fragment. The other 499 shot. Wow. You see the pressure? It pushed the dilator right out. Shot. Do you see it come out? Look at that. It shot out because there's so much inflammation here in this disc. Remember when I tried to do the discogram, I couldn't get the dye in? There's a huge tear back here. I can feel it. So it's actually pushing my tool out of the disc. Doesn't want it in there. That's just a lot of pressure. And that's all abnormal. The disc should not be under that much pressure, ever. Thank you. That's just from inflammation. Shot? Yep, we're on the front now. Shot, shot. Yep. All right, so as I advance the tube over the dilator, we're going to have to watch the dilator carefully and make sure it doesn't go backwards. Shot, it will go backwards, but we're going to have to stop and reset it every time it does. And I have a feeling it's going to go backwards a lot. Shot. There it is, already back. So we're going to have to push it back in. Shot. 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 Yep. You never want to advance the tube by itself because then you're just biopsying the disc. We're not interested in shot biopsying the disc. That's not why we're here. Shot. A biopsy is not good. That's for, sampling tissue. Shot. I can feel the pressure. Literally, it's pushing the dilator out of the disc. Incredible how much pressure there really is. Shot. All due to inflammation. Shot. And meanwhile, that inflammation is pushing on the painful back of the disc. So that's why the patient's constantly in pain, is that the swollen jelly is pushing out against the crack, the inflamed crack in the back. It'd be like rubbing a sore spot all day long on your finger or wherever you have, like if you have a splinter, it'd be like rubbing that sore spot all day long. And it would just hurt and hurt and hurt. And that's why people have neck pain and back pain from a herniated disc. Well, he's not going to have that pain anymore after today. God willing. All right, so this is our second incision. The first one is up here, much further north. And you can see it right there. Can you guys see that?
Yep.
So that's the first incision we did for 3-4. It stopped bleeding nicely. And we'll just kind of leave it there and keep an eye on it. Hold on. The sticky stuff, by the way, is called Ioband. It's a iodine impregnated membrane that helps protect the patient from getting any kind of infections. We've never had an infection with the Deuk laser disc repair. We've done over 1,500 surgeries, not a single infection. So this is the only spine surgery in the world that hasn't had an infection. All other types of spine procedures have infections.
We have a couple questions.
All right, we'll take the questions.
This comes from Sue Griffin on Facebook.
Hi, Sue. This is, by the way, this blue stuff is recently herniated disc. Go ahead with the question from Sue Griffin.
Yes, she asked, are you any further in challenging the insurers refunding? More and more in the support page seem to be struggling to get basic imaging. Not able that the reliance on MRI and ignoring symptoms seems to be another method to avoid funding surgical intervention. And she also added, 3 years since DLDR, still great.
Great news, Sue. It always makes me so happy to hear from patients that their lives are benefited from the procedure. But Sue, to answer your question, where are we with the insurance companies? So let me give you the forest from the trees, and then let me give you our little Robin Hood and his merry men perspective, okay? In the world, the insurance companies continue to restrict access to medical care for patients. And they do it by making what are called the indications, which they publish in their policies. They make the indications for getting diagnostic tests like MRIs or getting treatment. They make those indications narrower and narrower. What does that mean in plain English? It means they make it almost impossible to get insurance benefits, okay? I'll give you an example. So I was driving my car. I drive a Volvo, and I was noticing a week ago that my car, when I hit 80 miles an hour, And yes, I drive 80 miles an hour. Anything over 80, my car was going dunk, 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 right? My wheels were like bumping up and down. It was almost impossible to drive. Now, mind you, I lent my car to my daughter for about 2 months because her car was in the shop getting fixed. So I was driving a rental. But anyway, during those 2 months, she managed to go from a nice, smooth driving car to dunk, 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 dunk. By the way, this is a herniation right there. So when I bought the Volvo, not only did I buy the maintenance plan, which means they cover all the maintenance of the car, but I also bought this, any kind of damage to the car is covered, right? It's like an insurance plan. So I got the Volvo into the dealership, and they were looking at it, and they called me up and they said, oh, by the way, your wheels are bent. The right front and right wheels are bent. They need to be replaced. It's $2,000. And of course I said, what are you talking about? And then she said, yeah, you need to pay $2,000. And I said, no, I paid for insurance. And then she proceeded to tell me that, well, the insurance for the wheels covers only the new wheel if the tire will not hold air. In other words, if you damage the wheel and it still holds air, then it's not covered for a new wheel. It doesn't matter that the wheel is going dung, 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 right? And it's kind of unsafe to drive. They won't pay for it, okay? So the fine print of the insurance plan basically makes it almost impossible to get your new wheels, okay, covered under their insurance because of the fine print. You see, the insurance companies know why people need new wheels, and they basically write a policy that makes it so it would be almost impossible, because for the wheel not to hold air, you have to be in a pretty major wreck. And if you're in a major wreck, you're calling your State Farm insurance company. You're not calling the wheel insurance company. You know what I mean? They're not stupid. So they write a policy that basically doesn't cover anything. Irrigation looks like it's a problem. You guys got to pay attention to that. I know my stories are intriguing and all, but so what I'm getting at, Sue, is that the insurance companies over the last 20 years that I've been in practice, I'm looking at their policies of coverage, and they're getting harder and harder and harder to get anything paid for. Anything. You know, things that were paid for all the time in the past, it's almost impossible to get them paid for. And I'm not talking about new technologies like the Deuk laser disc repair. I'm even talking about fusions. Like, the insurance companies don't even want to pay for surgeries we've been doing for 50 years, like fusions. They call them experimental, unless the indications are what they want them to be. Okay? So just like I couldn't get my wheels covered by the insurance, and I had to pay out of pocket for new wheels, people are having to pay more and more out of pocket for things that are not being covered by the insurance, because the insurances are taking more money from the people every year, but they're not covering. They're covering less. So that's the forest view, the big picture view of what's happening in healthcare and health insurance. Now let's talk about Deuk Spine Institute. We are definitely fighting the insurance companies. We have a team of people that I have a lot of confidence in, that we are now submitting all of these surgeries for payment. If we're getting denied payment, we are appealing each decision, and we're appealing it with a lot of evidence of this procedure being, medically necessary is what we call it, because their basis is always that it's experimental, and it's not covered because it's experimental. And we're mounting a huge defense. If you ever watch the movie Gladiator, I like to think about the opening scene where the Roman army was positioning itself with its archers and cavalry and infantry, and catapults and trebuchets and the Germans, nothing against the Germans because I'm from Germany, but the Germanic tribes were in the forest with axes and clubs going up against the Roman army, I like to think of our efforts as being the Roman army, highly trained, very well prepped, and ready to go to war and win. And insurance companies like being the barbarians, because they are barbarians. Anyway, we'll see how it works out. I may need to contact Russell Crowe, get him to come help us. This is a herniation right here, by the way, pushing through the posterior ligament and through the posterior annulus. See it right there? I'm going to work on that. We're going to get rid of it. I'm going to peel it out. Now, tell me, the laser, look at that. There it is, right there. Incredible, huh? Bam. It's literally sitting right on top of the spinal cord. That's a fiber of the posterior longitudinal ligament. So this is C5-C6 for those of you who are wondering. And that, oh, yes. That is what I do this for right there. We call that a reverse herniation. Coined at Deuk Spine Institute for the first time in history and shall be used in perpetuity throughout history. That was a nice one, huh, Luis? Let's see this. Come on, turn the lights on. Bring the camera. We just pulled it out of the tube. Can you guys see this, Henry?
Yep.
Has it got a good view of it? Look at the size of that thing. That was sitting on the spinal cord, mashing on it. And we just fished it out through a tiny little tube without even opening the patient's neck up. This is the future of spine surgery, folks. Whether or not the insurance companies like it, it's going to happen because the people demand it. Better care. And that's what we're providing them. Was I facing this way or the other way?
Yeah, no, I think so.
All right. Any questions from our audience? So that's a good one for the testimonial.
Yes. Yes, we have a couple more questions. These next two come from Exist Outside the Box on YouTube.
Okay.
Love that
Exist outside the box. We had a question last week, I think, from that person.
Yes, a couple weeks ago, yeah. And I love the name. And they asked, does this procedure help with arthritis? Or does this procedure help with arthritis caused from disc protrusions and herniations?
The answer is yes. This procedure definitely helps with the arthritis. It essentially, the arthritis happening in the disc stops as a result of this procedure. That is exactly, arthritis, folks, is inflammation of the going on in a joint. And the joint here is the disc joint, okay? The disc is a joint. It's not a traditional type of joint. We call it diarthrodial joint, like a knee or a shoulder, but it's still a joint nonetheless. And any joints that get injured, like the annular tear we talked about earlier, those injuries cause pain. And the way they cause pain is through inflammation. And that inflammation within a joint is called arthritis. That is the medical term for inflammation in a joint, arthritis. And unfortunately, there's a lot of misinformation out there about arthritis. I mean, I've even read people who say arthritis is not inflammatory. Osteoarthritis is not inflammatory. That's like saying fires are not hot. I don't know about you guys, but I don't know any fires that are not hot. That's the most ridiculous thing I've ever heard. But there's so much misinformation in the world today, perpetuated by social media, perpetuated by the internet, just tremendous amounts of misinformation. And for people to say that osteoarthritis is not an inflammatory condition is like unbelievable. And I will literally go out there and say, yeah, but I'm a neurosurgeon. It is an inflammatory condition. And they'll say, well, you don't know what you're talking about. I think it's very funny. My kids tell me not to respond to those people. They say, don't even waste your time, Dad. There's too many idiots out there. And I agree. Unfortunately, there's a lot of stupid people. It's one thing to be ignorant, right? Like, I'm ignorant about a lot of things. I don't know how to tie a knot for a fishing knot, for a hook, right? I'm ignorant. But I recognize my ignorance immediately, and I'll tell you I don't know how to tie a knot for a fishing hook. Show me how to do it, you know? I'll ask the expert, show me. But these people, not only do they not know what they're talking about, but they don't even realize that they don't know what they're talking about. You know, a sign of intelligence is somebody who recognizes they don't know and even asks for help. So I recognize there's a lot I don't know. I'm perfectly happy asking for help. There's no arrogance here. I've learned a long time ago that there's no human being that knows everything. So, you know, you got to defer to the experts. Fact is that arthritis, osteoarthritis, is an inflammatory disease. And what's inflamed is the joint. Specifically, what's inflamed is the capsule of the joint. And that's the same thing with the disc. It's the capsule of the disc, which is also known as the annulus fibrosus. By the way, we need 5 minutes, we'll be done. 5 minutes, we'll be done. I'm just telling my anesthesiologist we'll be done in 5 minutes. That way he can start adjusting the anesthesia levels to wake the patient up soon. I've had anesthesiologists that you say, okay, we're done, and then the patient won't wake up for an hour. And those are, in my opinion, really bad anesthesiologists. Okay, why? Because you don't want the patient sleeping for an hour. Anesthesia, yes, it's necessary to do surgeries, but it's also not really healthy for the patient. So the sooner you get them out of the anesthesia, the better for the patient. And leaving them asleep for an extra hour is not a good idea ever. All right, next question.
This next question comes from Sylvia Norwood on Facebook.
Hello, Sylvia. Welcome to our broadcast.
And they ask, would this procedure be better for bulging discs in cervical instead of plate?
Yes, Sylvia, 100%. This is the Deuk laser disc repair. This is far better than plates and screws and even artificial discs. This is what we recommend for herniated discs and bulging discs. This procedure right here. Welcome to the broadcast. Did you watch the video, Sylvia? Didn't you play it just now, Henry? The comparison of the Deuk laser disc repair to a fusion? Or no, we haven't played that.
No, not yet, no.
All right, so we're going to show you in just a minute, literally in about 3 minutes, we're going to run a video for you that compares fusion, which is plates, to the Deuk laser disc repair. And you'll see there's no comparison. This is a much better surgery. Unfortunately, a lot of surgeons make a lot of money putting plates in patients. So they're not telling their patients about endoscopic surgery. Number one, they don't perform it. They don't know how to. But number two, they would lose a lot of money if they stopped doing all the fusions, because fusions pay so well. I make a lot more money doing a fusion than I do these surgeries. But this is better for the patients. All right, what are the other questions?
No current questions, but we do have a comment from Exist Outside the Box on YouTube, and they said, thank you, Doc. I can't wait for my procedure done with you. MRI is next. Please be safe during this hurricane.
Hey, thank you, Exist, and I'll pass that on to everybody here in the OR at Deuk Spine. We all appreciate it. I think we're going to be okay here. You know, we're on the opposite coast of landfall, and by the time the winds hit us, I think we'll be all right. But we're going to be closed up Thursday anyway, just so people are safe at home with their families if they want to be. Thank you for your concern. All right, just about 3 more minutes to go and we'll be done. This was the second disc out of 2 that we're fixing today in this patient, who is actually a local from Orlando. I know he's here with his wife, and I can say this, he has a lovely little daughter, Sophie, that I met. She's very cute. Reminds me of my daughter at that age. and I want to warn them. Take lots of pictures, videos, enjoy the kids while you can, because when they grow up, it's a little different. They're a little more challenging. I love my kids more than anything in the world, but teenagers are, you know, you make their challenges in their life part of your challenges in your life. So,
Very good.
all right, we are done. Go ahead and let's just show everybody real quick right here what we've got. Can you show them?
We see it.
All right, great. So it's kind of cool because you can see the first procedure we did was at C3-C4 up here, and now we're doing C5-C6 down here. We're done, and we're going to close things up. But before I do that, I'm going to put a little bit of antiseptic in. This is a topical antiseptic. We're not putting it in their veins. It's just going down and kind of cleaning out things where we were operating. It's very common in surgery. We use these topical antiseptics. Now we're going to irrigate it out. And what we use is betadine. It was developed by NASA to fight off any kind of potential bad bugs like viruses and funguses and bacteria and protozoans. The only thing I don't think it works against are prions. All right, here we go. We're going to come out and put a little pressure, and we're done. And the whole surgery was done through this tube, 4 millimeters. Go ahead, Luis. All right, folks, go ahead and type your questions up. I'm going to head over to the conference room in a few minutes, and I'm going to answer those questions for you face to face. In the meantime, Henry, if you don't mind, let's show our audience kind of the alternative procedure, which is a fusion, and why they really don't want to get a fusion done.
Deuk laser disc repair, a comparison with traditional spinal fusion surgery. A symptomatic disc causing neck or back pain can include bulging discs, herniated discs, ruptured discs, degenerative discs, protruding discs, spinal stenosis, radiculopathy, and sciatica. This patient can choose traditional fusion surgery or the Deuk laser disc repair to help alleviate the pain caused by and within the symptomatic discs. Here, two patients with comparable disc injuries are treated. On the left, the highly invasive spinal fusion, and on the right, the least invasive Deuk laser disc repair. The spinal fusion requires a very large incision, usually leaving a large scar. The Deuk laser disc repair requires only a very small incision, usually less than a ½ inch long. In this small opening, a cylindrical rod, called a dilator, is inserted to gently spread the muscle to create a small passage and guide through which the surgery is performed endoscopically. The incision for the fusion continues, including penetrating the skin, fat tissue, and multiple layers of muscle through to the bone. With the Deuk laser disc repair, a mallet is used to advance the tip of the dilator into the symptomatic disc. A tube, called the tubular retractor, slides over the dilator and is carefully positioned into the disc, again using the mallet. The rest of the entire Deuk laser disc repair surgery will occur inside this narrow tube. To access the spine, the spinal fusion requires the muscle to be separated from the vertebrae. This very invasive action causes trauma and permanent damage to the muscles. Whereas in the endoscopic Deuk laser disc repair, the muscle is not damaged. The endoscope camera is inserted into the tubular retractor to allow the surgeon to guide the laser inside each symptomatic disc. The fiber optic laser used in the Deuk laser disc repair is manipulated with great accuracy to remove only painful inflammatory tissue from the disc. In this highly magnified view, the laser is used to precisely remove damaged disc material that is causing the pain. The laser is debriding, or essentially vaporizing, damaged tissue in the disc's outer layer, or annulus, specifically at the annular tear, the source of the rupture or herniation and pain. After the fusion patient's damaged discs are removed, A metal or plastic cage housing bone grafting material is inserted in place of the removed discs. Fusion hardware, by design, is to fuse joints that normally move, preventing natural movement in the damaged portion of the spine. Whereas with the Deuk laser disc repair, there is no loss of movement. Normal movement and flexibility of the disc and joints is preserved. Once the laser has removed the painful part of the annular tear, the endoscope and tubular retractor are removed, leaving less than 1/2 inch incision in the skin, which is closed with a single stitch, Steri-strips, and a Band-Aid. Total time for the Deuk laser disc repair surgery, approximately 1 hour. The fusion, however, is still underway. Holes in the spine must be tapped in preparation for the large screws that anchor the fusion hardware. The Deuk laser disc repair patient is in recovery usually 45 to 60 minutes before released to go home. Meanwhile, bone graft material is placed throughout the fusion surgery site. These morselized pieces of bone will eventually grow together to help promote the fusion process. The Deuk laser disc repair patient is soon back home, enjoying life, with a very fast recovery, allowing normal activities without pain. Average surgery time of a traditional 2-level fusion is 2.5 hours, with an additional 3 to 4 hours in the recovery room. As we've seen, in comparison, a spinal fusion requires a much larger incision and results in a significant amount of scar tissue. The Deuk laser disc repair's 1/2 inch incision leaves no scar tissue around the spine or nerves. A large amount of bone is removed with a spinal fusion. With the Deuk laser disc repair, no bone is removed. Each disc is accessed through a natural opening in the spine. The entire disc is completely removed in a spinal fusion, even though only 5% may be damaged. The Deuk laser disc repair leaves the normal parts of the disc in place and removes only the painful annular tear on the damaged disc. Fusion requires hardware, including screws, rods, plates, etc. The Deuk laser disc repair does not require any hardware. The patient is totally hardware-free. Fusion surgery is very invasive. Cutting and moving the muscle structures and tissues for a spinal fusion causes trauma, resulting in permanent damage to the muscles. Whereas with the Deuk laser disc repair, there is no damage to the muscles. The Deuk laser disc repair is the least invasive surgery available to repair a damaged disc. With spinal fusions, patients are required to take highly addictive narcotic painkillers, which can cause constipation, bowel, and bladder complications. Due to the minimal pain, narcotics are not needed with the Deuk laser disc repair. Spinal fusions have a high risk for infection. The Deuk laser disc repair has a very low risk for infection. In the 7 years the Deuk laser disc repair has been performed, there have been no infections. Spinal fusion surgery has a very long recovery and requires a great deal of physical therapy and time to heal from the trauma in the muscles and the spine itself. Whereas the recovery from Deuk laser disc repair is in a matter of hours or days, rather than weeks or months. With fusion, the spine is being fused together, losing movement. Whereas there is no fusion with the Deuk laser disc repair. Normal movements of the joints in the spine is preserved. Spinal fusion results in loss of mobility. There is no mobility loss with the Deuk laser disc repair. In fact, most Deuk laser disc repair patients experience improved mobility after the surgery. The Deuk laser disc repair is FDA approved. All the instruments and equipment used are FDA approved. This proprietary surgery itself has been peer-reviewed and published and is performed exclusively at the Deuk Spine Institute. With the highest published success rate of 95%, the Deuk laser disc repair is proven to be the most successful and least damaging spinal surgery in the world for the treatment of symptomatic damaged discs causing back pain, neck pain, sciatica, and radiculopathy due to herniated, degenerated, or bulging discs.
I'm Dr. R. Deuk-Machen, and I was just in the operating room with you a few minutes ago performing a repair. We call it a Deuk laser disc repair. This is a procedure that has been established and performed for 16 years here in Florida at the Deuk Spine Institute. The surgery uses some basic techniques that involve what's called endoscopic spine surgery. And endoscopic spine surgery is really surgery done to minimize the amount of trauma to the body and keep the incision very small and not cause a lot of the collateral damage we typically will see with open surgeries. Damage to muscles and ligaments and joints, that's typically seen with spine surgery. We don't have those type of injuries with endoscopic surgery. So the idea is to get in, just like SEAL team got in, get the bad guy, Osama bin Laden, or the herniated disc, and get out without anyone ever seeing you or getting involved. So minimize collateral damage, strike the target, and only the target. And that's what the Deuk laser disc repair does. Now, let's take a look at this right here. This is the basic structure inside the neck. Okay, deep inside the neck, we have bones, and between the bones, we have something called the disc. And in this particular example, we have the bones are hard and they're plastic, and between them is the disc. And the disc is really a joint. It allows movement of the bones. That way you can flex your head up and down because these bones are moving in flexion. Okay, we call it flexion and extension, flexion and extension. You can see the disc itself is moving as well. All right, and when you carry things, you're actually compressing the bones down on top of each other or squeezing down on the disc. Now I want to show you right between there. Can you see it right in the back there?
Yes, yes.
There's a little tear, and if you put pressure, the jelly gets squeezed out through the tear. Okay, that's the herniation right in the back of the disc. And there it is again. I'm putting pressure. So when you bend forward, you squeeze jelly out through the tear. And that's why when people are active, lifting things, doing things, that's when their herniations really bother them. So what do we do at Deuk Spine? Well, what we do is we actually go through with a tiny little hole right through the disc to the back. Now I'm going to use a bigger disc to show you. We get to the back of this disc, and that's where the bulge is, right? That's where the tear is in the back wall, called the annular tear, in the posterior wall of the annulus. And then you have the herniated disc, which looks like a bulge. And it's really the jelly from the center pushed out. And I basically use a laser just to laser all these little pieces out that make up that bulge. We call it a herniated disc, but it's really not one herniation. It's usually 20 to 30 pieces that make up that herniation. You just can't see the individual pieces unless you do endoscopic spine surgery like we did today. And if you go back and watch the surgery, you'll see I took out lots of pieces at each disc that make up the actual herniation seen on the MRI. So the endoscope is the most sensitive test to find herniations and remove them. And we use a laser, which is extremely precise, to do the work safely. All right, we have some questions. Let's take our questions.
First, so we have a comment from Saul Sotelo and on YouTube. And he said, I am very excited that I found you. I will submit my stuff tonight and hope to see you guys very soon.
Thank you, Saul. We're very excited for you as well.
And these next questions come from Sylvia Norwood on Facebook once more.
All right, Sylvia.
And they asked, yes, so this is from the follow-up question she asked before. She's like, yes, I have been watching the video. What about muscles? What about muscles next to the spine? I am in constant pain for 7 years. And also, where are you located?
Okay, great. So we are located in Orlando, Florida, just outside of Orlando, about between the Orlando, which is in the center of Florida, and the coast, where SpaceX is launched. It's called the Space Coast of Florida. So we're really located near NASA at the Space Coast of Florida. It's a 45-minute drive from Orlando from the airport. And the other part of the question was...
yeah, what about muscles next to
the muscles?
Spine? Yeah.
Yeah, so the good news is when we do the Deuk laser disc repair, we're not damaging any muscles because we're going between the muscles. When you saw me in the beginning, I put my fingers here and I touched the spine. That's not possible to do unless the muscles are relaxed. The patient has to be intubated and asleep like they are. And when we relax the muscles, I can move them to the side, creating a small passage between them that's only a few millimeters wide. And then I can get into the disc without damaging any muscles. Now, you know, when people get fusions done or they have open surgery, that the muscles are damaged, but not with this surgery, not with the Deuk laser disc repair. When you're putting metal plates in the front of the neck or in the back, there's definitely going to be muscle damage, but not with the Deuk laser disc repair. As far as the muscle pain you think you're experiencing, it's not muscle pain. It's pain coming from the herniation and the tear in the back of the disc. A lot of people are told it's muscle pain, but it's not. If you have muscle pain, it's always secondary, coming secondary to the pain from the herniation. Muscles by themselves almost never cause pain. The only time you get actual muscle pain is when you're in a car accident and you have a whiplash injury to your neck, some type of trauma, and then your muscles can tighten up for a few days, but then it always goes away. Those are whiplashes. Whiplash pain always goes away within a few days. The other time you get muscle pain is if you have meningitis. So say for example you have virus meningitis. That will cause the muscles to tighten up for a few days while you have meningitis. And then the other time you'll have muscle pain is when you have surgery done on the back of your neck, like a laminectomy. The surgeon's gonna ruin your muscles, destroy them, and while they're dying, they'll be releasing chemicals that cause severe pain and swelling. So avoid open surgery and you won't have those problems with the muscle.
Alrighty, and this, last but not least, we have another question from Saul Sotelo on YouTube. And they asked, what would be an example that this surgery, or what would be an example that this surgery can no one be performed?
So Saul is asking, what's an example of a situation where the surgery cannot be performed?
Yes.
The answer is if you have a fracture in your spine. So if you have a fracture, we would not do the surgery. But 99% of people with problems in their neck have a herniated disc, bulging disc, slipped disc, protruded disc, ruptured disc, extruded disc, disc osteophyte complex, stenosis, radiculopathy, spondylosis. All of those conditions are treated with this surgery to get rid of the pain and discomfort in the neck. All right, I hope you enjoyed our broadcast. We'll be back in 30 minutes with our next broadcast. This will be a one-level cervical Deuk laser disc repair on a lady who is originally from Indianapolis and has come down for the Deuk laser disc repair for a herniated disc at C5-C6. So that'll be a one-level surgery. And then after that, we'll have 2 lumbar Deuk laser disc repair surgeries.